Thank you very much. I'm going to talk about connecting up. I must say it's a huge thing to be able to relate to everybody here in this big auditorium, but with all this technology, but we'll try. I'm delighted to be here, and I want to really talk about the power and the capacity of social networks to bring about different approaches in the way that we might address how we support and mobilise resources for self-management support for long-term conditions, but perhaps for other types of conditions as well. So the title of my talk is, Can Social Networks Support Minimally Disruptive Medicine Through Promoting Connections and Mobilising Resources Outside of Formal Healthcare? And the focus on outside of formal medical care is really quite important. So this term, minimally disruptive medicine, it's used by Victor Montori from the Mayo Clinic to talk about a different way of relating to patients and to actually kind of reduce the burden of treatment on individuals. And so the definition of that is a service-driven approach to care, co-created with patients. So the emphasis is on co-creation there. And the notion is that it should make sense and connections to patients to meet their goals with evidence-based approaches in a manner consistent with their needs and preferences. So self-care or self-management is part of that aspiration for co-creation with service providers, and it's been promoted very much as part of models encouraging better chronic illness management in the States, here, Europe, and elsewhere. Support for self-management is often seen as focusing very much on an individualized approach towards encouraging and engaging patients with self-skills training to enhance the way they might adapt their lifestyles or about managing long-term conditions. And of course, that is quite a very important part of self-management support. But actually, I think it misses a trick, and this is the whole thing about it being very focused on the individual. Whereas we know we're all part of larger communities and we connect in with a range of other people and resources. And so the idea here of introducing the notion of networks is because networks have the capacity to link people into more social involvement, and also the very important things about the resources needed to self-manage. And so that's the focus, is perhaps away from the individual more towards the network's capacity. And so why have we come to think about that in the research that I've done in Southampton and at the University of Manchester, is that the models for chronic care have been very predominant, and they've been extremely useful in focusing people on the need for chronic illness management and disease management in primary care, and indeed around self-management support. But there is this focus here of the productive interaction being seen as related to the informed and activated patient linking directly into a clinical team. And whilst that's important, it does tend to define that quite narrowly, the area of action. And so I wonder whether it's time to move beyond that. And this is an evidence-based in terms of actually why we should be moving beyond the consultation and beyond the primary care. This is a diagram here of the outcomes of an extremely large randomized controlled trial published in the BMJ 2 years ago, which sought to roll out a menu of options of self-care, train general practitioners and practice nurses and the whole practice in delivering self-management in order to achieve better outcomes. The trial was a huge success, but the intervention was a complete failure. More than that, the people in the control group had better shared decision-making at 6 months, i.e. in ordinary care was better than the self-management support intervention. So we're obviously very disappointed that this whole system approach that we've taken didn't work in primary care, but it did point to the fact that we do need to move our vision beyond primary care to something else. And so what one has to look at is the components of support that are available to patients and the public in managing a long-term condition, and all of us really. And actually, it is quite diverse. It doesn't begin and end in the consultation. In fact, these systems of support involve non-health professionals, personal communities, volunteering community groups, as well as health professionals. So if we see these as the areas of components of support that potentially could make up self-management support, that's where we want to start from. And then if you lay that across the wonderful Kaiser Permanente triangle for chronic illness management, you can see that actually everyday life is the main part of which people are managing a condition, not their contact with health professionals or health services. And then these other components come very much into play in looking at how people might best be supported. And so I suppose what we're aiming for is a model in which we get some dynamism going between the personal communities, the people with long-term conditions, with the resources. So this is what we're aiming for, moving from a triangle to a circle. I want to talk about the power of networks because I've been very influenced in the research that we've been conducting by Nicholas Christakis and John Fowler, originally from Harvard, who really started to say, should we be looking at the power of networks in terms of influencing lifestyle and key behaviours rather than focusing on the individual? So they had access to a large, extremely large database, the Framingham Heart Survey, which by definition looked at the connections people had because they were trying to find out and predict who would suffer from a coronary event later on in life and how that was connected to other relatives. And they use this as well in a sort of public health orientated way to demonstrate many things. One of them is the idea, for example, that weight gain and loss isn't so much an individual factor as happening in collectives. So if one person gains weight, they tend to be associated with gaining weight in other people in their network. The same with smoking. They found that smoking behaviour spreads through close and distant social ties, and also the giving up of smoking does that as well. So their focus is on the groups of interconnected people looking at stopping smoking, for example. And I thought about this in relation to, well, how can this be applied much more to chronic illness management if we're looking at things that are related to collectives rather than individuals? So the work that I've been involved with really focuses on the workforce, dynamics and outcomes of patient systems of implementation for self-management support. So we hear a lot about professional systems of implementation, but really we're in uncharted territory when it comes to looking at the kinds of systems that patients have for managing their healthcare. We talk about relatives and providing a lot of care and support, but it sort of ends there really, and it's always looked at in terms of dyads really, the patient and their significant other, and not really looked at in very much detail. So there's been 4 elements to work over the last 5 years: the nature and capacity of self-management support workforce, the lay workforce, the relational work and attributions of meaning that are related to self-care, and looking at the way in which perhaps social networks can generate the mechanisms of capabilities involved in social network support. And of course, we're interested also in outcomes. There's no good actually saying, oh, this is a great idea, if we can't show that actually having a broader social network or how the social network might actually influence outcomes. So I want to sort of talk here about the workforce and division of labour. Who is involved in the management of chronic illness? And in relation to people with long-term condition, this relates to bonding ties, weak ties, family members, professionals groups, a whole range of groups of people. And also the division of labour, who does what. So we're looking at the amount and distribution of chronic illness work and how that differs between networks. A lot of this work came from the NIHR Greater Manchester CLAHRC, in which we undertook a survey between 2010 and 11 of 300 participants involving mapping networks of all those people, which led to looking at 2,544 networks in terms of their contribution to illness management. We've used the term types of work, again, to get away from a very individualised approach, because work implies that you work in concert with other people. It also sort of takes it out of a sort of medical framework, really. So we looked at different types of work. So illness work, we looked at a set of questions about the way in which a person might help with the day-to-day management of chronic illness and who does what. And it relates to different types of work, how people coordinate work, advocacy work, as well as the illness work of doing things like taking medication. We'll also talk about everyday work, because people don't just do illness work. People run whole households, hold down jobs, look after children, those kinds of things. And then there's also the issue about emotional work and biographical work, the notion of comforting people and providing emotional support for a person in their everyday life and also in relation to their long-term condition. So I've put this up here because this is the concentric circle diagram that we used. It's also a participatory method. So this method was first used by Spencer and Pull to look at friendship networks. And the idea is there's 3 concentric circles with the ego, or the person with the long-term condition, right there in the middle. And then we asked people, who helps you with your long-term condition, or who's important to you in managing your long-term condition? And then on top of that, we looked at, well, what they actually did. And we asked people to actually put in the circle in terms of the importance. So right in the middle, central circle there, it's the people most important to them. And the second circle is less important, but still quite important. And the outer circle is still important, but in a lesser way to the 2 inner circles. So here, this person has mapped out their networks. And actually, they have a very, very rich social network here, because they've got people populated in all sections. They've got groups and voluntary groups. They've got friends, they've got professionals, and they've got close kin helping out. So that's just a demonstration of how we do this network. And we use this basic idea in a number of ways. We've used it as a research tool. We're now using it as a form of intervention in terms of engaging people with looking at their support needs and using it as a means of perhaps connecting them up to other resources. So this, although it looks like a very simple tool, it's actually quite an effective participatory method as well as a research method. And then you can do fancy research things with them. You can draw diagrams with them. On this one, it shows the way in which people's subjective awareness and importance of a person is mixed together with what people objectively do. So, for example, John there in the middle, who's the partner, he does an awful lot of work from asking a range of questions, but actually the person who was asked didn't rate John very highly, or perhaps as highly as they might do in terms of the actual work they're providing, perhaps something there to do with intimacy, whereas the red blobs actually show a huge amount of subjective importance placed on the person. So here, Kate and Jane, who were friends, received both an endorsement in terms of the subjective rating and in terms of objective provision of care and support. And there you've got the cat. We'll come on to cats in a bit. What did we learn, really, the work and workforce of self-management support? I'm just going to whip through just a few of the findings. So, not surprisingly, partners and close family make the highest contributions to providing support for illness management. That's no surprise. We've known that before. But I think this method also shows that there's evidence of inputs from a wide range of relationships that go beyond that. I'm going to come on to talk about the importance of weak ties in a minute. We also found that the network characteristics are actually really important. So the type of relationship a person has to the individual. Proximity is very important. So people talk about the internet or contacting people by telephone. Yeah, those are very good, but actually in providing consistent support, being proximate to somebody is really important. So it suggests that we ought to be looking at the locality and the localization of resources as providing most support, and also the frequency of contact. Not necessarily the intensity of contact, but the frequency of contact, that it's regular, even if the contact is not substantive in terms of amount of time. So all of that impacts on the amount of illness work a network member undertakes. We also wanted to look at the issue about substitutability, particularly because we're focused on this idea of informal care from partners. So what happens in networks with no partners, for example? And in fact, other people, other close family members or distant family members, actually, in the absence of that, contribute more illness work. So where you've got a partner, other people contribute less, but where the partner goes, there isn't around, then other people do tend to substitute to an extent. So there is an extent of substitutability. The other thing is the type of input by different members changes according to circumstances, and we're going to come back to that, what happens when somebody gets sicker. What do we mean? We talk about relational work and the attribution of meaning. And the attribution of meaning is quite important to people because I think this is something that hasn't really been looked at very much in terms of issues to do with care planning, for example. One assumes that the person is there, going to assess their needs, and that we're going to provide care for them in a sort of way. And I think one of the things that's really impressed me about this work is the need for people to continue to be reciprocal in their relationships. They do not want just to receive care without giving something, whether that's walking a grandchild to school or continuing to be a parent, a grown-up child. They do not want to change that basic identity. And I think that's really important because I think some of the models that we're propagating at the moment don't take account of that. Very influential in looking at some of the accounts of people in the networks were the idea that they didn't want grown-up children to be responsible for their health. And so grown-up children were often wanted to contribute more. They wanted to engage their parents in care. And people did not want that because they wanted to sustain their identity as parents and also the idea of people getting on with their own lives. So one has to really take that into account. And I think this attribution of meaning really came through when we looked at the people who had identified pets as being important in their network in providing them with support. So we know that pets have a therapeutic function for people. That's out there in the literature. But what we don't know is what the meaning is for somebody with a chronic condition. So we found that in interviewing people around where they'd placed pets in their networks is that they don't actually see them the same as human beings. That's not surprising. And pets have unique qualities. They're not simply substitutes for human relationships in long-term condition management. For example, pets contribute mostly to managing emotions, emotional work. They came out far better than GPs. You could think of a nice headline there. Go to your pet, not your GP. So in terms of providing emotional succour, then pets did it much more than other groups of people. It also enhanced a person's sense of self-identity. It allowed the idea of reciprocity in feeding a pet, walking a pet, loving a pet, providing for the needs of a pet was really important for people. And it also continued a self-identity of somebody as a pet owner, which they'd had before having a long-term condition, which was also something highly valued. They're also in control of the relationship. Is you can choose your pet. So people chose pets that suited their long-term condition, a cat, for example, and they had very specific ideas about what the nature of the pet should be to support them. Now, whilst we can do that perhaps once in our life or maybe twice with a sort of very close partner, we don't go around changing our partners to that extent in the way that we could with a pet. So obviously pets didn't do practical tasks in the same way as other members or professionals, but they do also mediate relationships for people living with a long-term condition through weak ties with others in the domestic and community settings. And once you know that, you will never walk into your park and not notice that you're talking to the dog first before you talk to the owner, but you will talk to both. And with people with long-term conditions, that can be somebody coming in to feed a cat or talking about the cat or whatever. And when people are becoming increasingly isolated, the salience of pets, social network members, increases. Now, I'm only focusing on pets just to illuminate, I think, this idea of relationships beyond very core ones that actually provide a set of resources for support for long-term conditions, and that we shouldn't be ignoring that. And I'd like to come the day where actually you can actually get a pet on prescription, perhaps, or something like, or try to sort of engage these other kinds of pets as relationships. But it also relates to what we call weak ties. These weak ties are the people in your local community that might know about a job. If you're looking for a job in relation to people with long-term conditions, it's related to neighbours, it's related to taxi drivers who may take you from one point to another to actually get food or take you to an appointment, and people in your locality who might support you through a voluntary organisation. So people that you have frequent contact with, but the relationship isn't an extremely intense one, and often it involves some kind of cash nexus. Again, this whole idea about reciprocity is very important. You pay the taxi driver to take you to your appointment, therefore you have a kind of relationship with that person that's more equal, or at least it's not a completely dependent one. And so weak ties make up about 16% of people's social networks, and that these weak tie resources seem to be very important. So one thing we've learned is that the diversity of a network is very important in providing structural resilience in terms of having a long-term condition. So an ideal type network for somebody with a long-term condition is one that does have close, intimate relationships, but also has a diversity of networks that can mobilize different types of resources. So what about all this? Well, it's all very well saying we think that networks work, but in a paper published last year in PLOS, we looked at the outcomes of people's changing networks over a 12-month period. So it was the original 300 people that we sampled in Greater Manchester. And what did we find about how the networks had changed, or from one point to another? This issue about diversity comes through well here, because we found that social involvement with a wider variety of people and groups supports self-management and physical and mental health well-being. So those people who were involved in voluntary groups reported better physical well-being and higher rates of self-efficacy. We found that this idea about substitutability, that as people's illnesses got worse or people had repeat episodes, the help from personal networks increase in accordance with health needs. So there's a positive care law going on there in terms of helping people with their condition. But interestingly, given how long health policymakers have been trying to make a connection between self-care support and a reduction in utilisation and costs of health services, we found the notion that where there was people with a well-supported network, they did tend to substitute for formal care. And the health economics analysis showed that it can potentially provide substantial savings in traditional health service utilisation. This was indicated by the fact that costs were significantly reduced for patients receiving greater levels of illness work through their networks. So this is the start of connections showing the evidence for the capacity of networks in chronic illness management. So what do we do with all of that? First of all, we need to know what the mechanisms are that make that work. So we've done the mapping work, we showed the outcomes. So through a metasynthesis, we tried to have a look at other papers that had, in fact, looked at networks and how they supported people. And so we've come up with these three potential mechanisms that we think are working or are needed to support chronic illness management. First of all, network navigation. That means identifying and connecting with relevant resources in your network when you have a long-term condition. And that involves making decisions about when and who to contact, and looking at previously unused resources from when you didn't have a long-term condition, and perhaps conceding the selection of some ties that you want for supporting your long-term conditions from other ties that you want for other purposes, leisure, pleasure, intimacy, those kinds of things. They're not necessarily the same thing. Then there's this issue about negotiating in networks to reshape relationships, roles and expectations as a way of engaging and communicating between network members. And then most important is this notion of collective efficacy. So we know about self-efficacy and how important it is to give people confidence to manage their condition more, but collective efficacy relates to a shared perception in the network to successfully change behaviour through shared effort, beliefs, influence, perseverance and objectives. So it's a wider notion, and here is this whole thing that came through in the longitudinal study, which showed the issue about social involvement actually increasing self-efficacy. So we think there is a relationship there between collective efficacy and self-efficacy. That instead of focusing simply on self-efficacy and self-management support, that perhaps collective efficacy is one way of getting better self-efficacy and better self-management. So trying to link the collective with more individual self-management. These are, again, informing our work as we go along. So obviously, we've got to try out some interventions that reflect some of our new thinking. So this is the Bright trial by Blakeman and Blickham et al., which we did as part of the Greater Manchester NIHR CLAHRC. And we looked at 436 patients with early stage CKD, chronic kidney disease, recruited from 24 general practices. And the intervention in this was not anything actually in primary care. It was a booklet about keeping your kidneys healthy based on a patient-centered, evidence-based method that's been used previously. And we used this together with a connecting up tool, and this was mediated via the telephone. So as well as the person would receive the booklet, and then somebody would ring them up and talk to them about whether they wanted to do a set of activities, whether they wanted to connect up through a dedicated tool. So I always get used to, after the big randomized controlled trial in primary care, everything being coming out with a negative result. And I'm a sociologist, so I have to think in a very negative way. But actually, findings at 6 months showed that there were, in this exploratory trial, significant differences in blood pressure control. So good blood pressure control, which is a marker of good vascular health, was maintained in the intervention group but not in the control group. So it deteriorated in the control group but not in the intervention group. And that there were significant improvements in health-related quality of life and reduction in costs in terms of healthcare utilisation for the intervention group. So it's an exploratory trial, but it starts to introduce this idea of connecting people up to resources alongside other information around self-management support. And we're now taking this further in personal community mapping and analysis, and this forms part of a large FP7 grant and also the NIHR CLAHRC Wessex, where we want to use both the personal mapping and the links to resources to actually think about self-management support in a wider context. We want to take it online, so this is a prototype of Eugenie, what we call Eugenie, in which this shows the idea of a set of activities around learning and support independent living that people might want to do. And we've taken the network tool online. So we get people to map this out online. They can still do it face-to-face with a facilitator, and we try to connect them up to resources through a questionnaire, a platform. And we then, when they're connected up, we look at where that is in the locality and try to connect people to those resources. And then we're following them up to see whether they've utilised the resources and what happens. So the Isle of Wight has proved a wonderful training ground for this, being an island, right? People are actually quite connected up. So we've tried it out in the Isle of Wight. We're looking at the results now, and we're trying to spread the tool also as a new way of doing things through mainly care navigators, health trainers, or anybody else who wants to use it. So we are actually providing training in that, and we're trying at the moment to spread that throughout the Wessex area. So from Isle of Wight to Dorset, as well as throughout Europe and with different groups. So in summary, I'd just like to really talk about network support approach in relation to chronic illness. So I think from the work that we've done in filling the epidemiological gap, as I call it, there's growing evidence and understanding about the effectiveness of network support in improving health. And the next question is how we use this knowledge to translate into a range of interventions and to move away perhaps a little bit from the individualised approach that we've adopted to date. So it does suggest we could actually intervene to change structure and dynamics, very difficult thing to do. One of the things is to look at how one might, for very isolated people, for example, and isolation is an increasing problem with people with long-term conditions. They identify loss of network members and isolation as a big thing, as well as other research that shows that, is look at how we can increase network diversity and collective efficacy. So trying to focus on those two elements in interventions and approaches to healthcare. The idea of building awareness of networks for individuals, healthcare practitioners and communities. Should actually healthcare practitioners be more aware of the networks that people have? Should they be concentrating more on focusing on people who have very small networks rather than people who have very good and diverse networks as a way of trying to link people into scarce resources? So I think there's a building awareness for the individual themselves in terms of their engagement with resources. And people do really like doing the network mapping method. I don't know why. We're trying to actually understand why, but it's something about focusing outwards rather than inwards on themselves. So there's an awareness of people's own capacity and trying to look at themselves in a slightly different way in linking them up. But there is also, I think, capacity to build awareness for healthcare professionals and in local communities. We need much more local knowledge to increase social capital. And there are a growing number of directories and information, but we need to keep that local knowledge up to date. Often people construct directories and they're out of date, so we need to actually have that as a core public health facility, for example, in local authorities and elsewhere, to actually keep that knowledge up to date so it's of use to people. It'd be good also if we had TripAdvisor ratings of that so that it's accessible for people and they know what they're going to get and comments and those kinds of things. And we need feedback and information to actually aid planning at the level of CCGs in order for them to be able to commission the types of approaches that are going to deliver the positive outcomes that we've illuminated earlier. So our big job in NIHR, CLAHRC, and probably for the rest of my career, is to look at the integration, implementation and sustainability gaps and try and look at how we might fill those and how we might develop interventions that actually prove to be more effective than the current approaches to self-management support. Thanks very much.